Two, one. Please start, sir. We are live.
Hello, good evening, everyone, and it's a pleasure to welcome you all for this webinar, which is on the lung cancer treatment update. It's a pleasure to welcome our convener, Dr. Manish Sharma. Hello, sir. Good evening to you. Dr. Manish doesn't need any introduction. He's a senior consultant and head of unit medical oncology at the prestigious Rajiv Gandhi Cancer Institute and Research Center, New Delhi. So, once again, a great good evening to everyone. And without wasting much time, I request Dr. Manish to introduce and set the context for today's webinar and invite the next speaker, please. Over to you, sir.
Good evening, all, and it's a pleasure to be here. And thank you so much, all of you, for joining, my colleagues and my friends. So, lung cancer is the most common disease amongst cancer, and it is the greatest killer among all the cancer in the whole world. And uh, important thing is that the lung cancer is one of the disease in which the maximum amount of newer discoveries are taking place, and this is most importantly the era of targeted medicine. So we have a few speakers lined up with us. We will have three sessions on targeted therapies in lung cancer, and most of them will be speaking on EGFR mutant lung cancer and some of the other mutations in lung cancer. This will be followed by a panel discussion by Dr. Praveen Jain. So our first speaker is Dr. Rajat. He is a senior consultant in Fortis Hospital, Noida. He will be speaking on how to sequence EGFR TKI to maximize overall survival in EGFR mutant lung cancer. Dr. Rajat, I welcome you here. Thank you so much. Please take it forward.
Yeah, thank you, Dr. Manish, for having me here. And I think Ankit will be sharing the slides. Yeah, he already has. Yeah, am I audible?
Yes, Dr. Rajat, yes.
Yes, okay. And the slides are also visible, I think.
Right, and this is the most
Right.
common question. Yes.
Yeah, I know. So, thank you once again, all the organizers and the organizing team for having me here. So, we are here to discuss the effective sequencing strategies for mutant EGFR non-small cell lung cancer patients in 2022. How do we really plan our treatment strategies for these patients who come to our OPDs? Can I have the next slide, please? So we have a few options going with us when we consider the treatment of first line mutant EGFR non-small cell lung cancer. We can go ahead with EGFR TKI monotherapy. We can go ahead with EGFR TKIs plus anti-angiogenic agent combination, and we can go ahead with EGFR TKI plus chemotherapy combination as well. When we talk about EGFR TKI monotherapy, we have the first and the second generation TKIs, and then following it up with third generation TKIs on progression if T790M mutation is present. Or we can also go ahead with a third generation TKI upfront, which happens to be osimertinib as one of the major molecules, or rather the only molecule of third generation TKI which is available with us in the Indian market nowadays. Next slide, please. So, when we talk about the sequencing options, I'm sure all the medical oncologists here would agree that we want to sequence our strategies for any patient, so to say, in a manner that it becomes convenient for the patient to take the therapy, as well as it maximizes the overall survival. Also, the available options can be many in first line and second line, but only when we carefully sequence them does it make sense for us to tell the patient that the overall survival can be maximized. In that regard, we have these options, like I said in the beginning. So we can start with a second generation TKI and then go on to have a third generation TKI, which is osimertinib. But this strategy is only for patients who have got a T790M mutation positive on either a rebiopsy or a liquid biopsy, which is done post progression on a second generation TKI. Why a second generation TKI in the beginning, and why not a first generation in the first option is because of certain real world data that we have, one of them being the geotag study and the other being the select study, where it has been seen that the overall survival can be increased to the tune of about 4 years. Although this strategy has not been prospectively studied, it is a study where it is a strategy where most of the data which is there is a retrospective data or a real world data. Also importantly, like is mentioned, that it is only for patients who have got a T790M mutation positive on progression. Then coming on to the second strategy, which is first generation TKI plus anti-angiogenic agents. So we have the the combination of erlotinib with bevacizumab, which can be there, we have the combination of erlotinib with ramucirumab, which is there, which is the relay study. And then these patients can later be the patient can be started on osimertinib again if the T790 mutation is positive. There is data to suggest that about 25 to 30% of these patients can be T790M mutant on progression, and these patients can be given the benefit of third generation TKI, which is osimertinib on progression. Here also, post progression in the relay study, the overall survival has been seen up to the tune of 2.5 years. Then we come to the third strategy, which is first generation TKIs plus chemotherapy, and then following it up with third generation TKI. So we have our own Indian data from TMH regarding this, with the use of geftinib plus pemetrexed plus platinum combination. We also have two other data sets here to suggest that this combination can work, and the PFS is also good to the tune of 16 to 18 months, almost similar to what osimertinib does in the first line. But then we don't have much data to suggest that how much will be the T790M mutation population post this 790 mutant. Then of course osimertinib can come in as a second line to give us a PFS of about 10 to 11 months according to the AURA3 study, and then the overall survival can be calculated in that way. And of course, the fourth combination, which according to me is not the way it is written, probably this is the most common approach that we follow in our daily practice, is the usage of osimertinib in the first line setting to achieve the maximum benefit. We all know about the FLORA study I'll be talking about in the subsequent slides. Yeah, next slide, please. So like I said that the TKI monotherapy is one of the options for sure, and be it the first line or the second line or be it the first generation or the second generation or the third generation TKIs, we always fall back on the scientific evidence. We have the evidence of PFS and overall survival. So over the good data in the EGFR positive space, be it the first line be it the first generation TKIs, where we have the IPA study for geftinib comparing geftinib with chemotherapy. We have the UTAC and the optimal study for erlotinib comparing erlotinib to chemotherapy, and the PFS has been to the tune of about 9 to 10 months compared to about 6 to 7 months of chemotherapy, and the response rates have been to the tune of about 65 to 70%. 0.6 in favor of the first generation TKIs. If we talk about the second generation TKI, which first came, which was afatinib, so Lux Lung 3 and Lux Lung 6 also pitched afatinib against chemotherapy, and we could have a good overall response rates of about 55 to 60% and a median PFS of a marginal improvement over the first generation TKIs on about 11 months. And then we have we had the Lux Lung 7 study, where for the first time two TKIs were compared, which is second generation TKI of afatinib with first generation of gefitinib, and the overall response rates were about 70%. Again, the PFS showing a marginal improvement. This improvement was more when we talked about the DEL19 patients compared to the exon L858R 20, exon 21 L858R point mutation patients, and that remains across the board. If we have DEL19 patients, the PFS and the overall survival is going to be better. And then lastly, if we talk about the third generation, we have the FLORA study where osimertinib has been compared with the first generation TKI, and we have seen that almost doubling of PFS is seen, especially when we are talking about the DEL19 patients. So osimertinib is the only TKI which has shown a significant improvement in overall survival, because if I have to speak about all the other trials apart from FLORA that I've mentioned, they have not had benefit in terms of overall survival, but FLORA has had a benefit in terms of overall survival, approximately 4 to 5 months of with the Kaplan-Meier curves, as we all remember, I'm sure, from FLORA separating very widely even after three years of usage of osimertinib. Next slide, please. So this is the FLORA study design. I'm sure all my August audience does know this particular FLORA study design. And osimertinib in the standard dose was compared with EGFR TKI, which was first generation, either erlotinib and gefnib. And the primary endpoint was PFS, and the secondary endpoint was overall survival, which was both met in the study. Next slide. If you look at the forest plot, if one would see that very importantly, both the DEL19 and the L858R patients, they benefited. And this is when we're talking about the benefit, we're talking about the PFS here. And very importantly, like I said in the beginning, that this strategy of first-line osimertinib is favored by most is actually because of its CNS penetration, and it has been seen that not only the patients who had brain metastasis upfront, or also the patients who did not have brain metastasis, there also the time to brain metastasis was delayed to a significant extent with the use of osimertinib compared to the first generation TKIs. Also, needless to say, if you look at the Kaplan-Meier curve on the left, is certainly better for osimertinib compared to first generation TKI, with a wide separation of the KM curves, and that to a very early separation is a sight to behold, and it further boosts our confidence in this particular third generation TKI molecule. Next slide. So like I said, that separation of curves is very important. I, as a medical oncologist, would certainly like to believe that if I'm giving a therapy to the patient, this therapy should make a dent in the disease earlier than its comparator arm in the clinical trial. And if you see, although not fair to compare the trials, the cross trial comparisons, but still Lux Lung 7, if you see on the left hand side, the middle one being the Archer 1050, which is dacometinib pitted against the first generation TKI. And then if you look at the osimertinib, the most early separation of curves that you see is in the FLORA study. Next slide. Also importantly, like I said, the brain metastasis patients, Archer did not include brain metastasis patients. So that also is a very important point of concern once we are talking about the factors which we consider while choosing our first line options. So we have to look at the PS of the patient, the comorbidities. We have to look at whether the brain metastasis is present upfront or not, whether the patient is DEL19 or L858R mutation. Remember, we are talking everything about the common EGFR mutations. We are not talking about uncommon EGFR mutations here. So all in all,
request you to conclude your session in 2 minutes.
Yeah. All in all, we do understand that when we are talking about osimertinib, almost all the boxes get ticked. Yeah, next slide, please. So the overall survival also was improved, and this we have already discussed. Next slide. Now, if we're talking about the sequencing, the TKI monotherapy, so we have the option of starting dacometinib upfront, and then once the dacometinib was started in the Archer study, only the 10% patients who received dacometinib, they received osimertinib in the latest study, and the survival was to the tune of about 3 years. So this also is very important, that only 10% patients could receive osimertinib, which is the best TKI that we have till now. So the incidence of T790M post dacometinib is something which is still unknown. And 10% is a figure that is there in front of us. So sequencing of dacometinib first, followed by osimertinib, how many of these patients are going to really benefit with this sequencing is something that is still unknown. Next slide. The Kaplan-Meier curves, we do know that there is a crossing of the curves in the dacometinib in the overall survival, although the overall survival benefit was there in the dacometinib study. Next slide. And also there was a problem in the hierarchical stratified statistical designing of this particular study. So we have to take notice of that fact as well. Next slide. We have seen that there has been an issue in the forest plot of Archer study as well, with the Asian versus the non-Asian population, and the DEL 19 versus the L858R population as well, which was not there in the Flora study. Next slide. Next slide, please. So we have another option of first starting with afatinib and then taking it further with the third generation TKI if the patient is T790M mutant. Here we have the geotag data, the real world data, to suggest that the overall survival was 41 months. But again, this is a real world data. We don't have prospective studies. We don't have the Indian data to suggest that. But this certainly is one of the options that can be carried out. Next slide. Also, we have to use our best bet upfront, because as the case progresses, there are many patients who would have attrition of therapy, who would lose their good general condition, who would fall out of treatment for various reasons. That is why they are not able to really get the best TKI, which is osimertinib, in the later line of therapy and get the benefit out of it. Next slide. And of course, if we talk about the studies for the incidence of T790M mutation post afatinib, there also there is a dichotomy. The data is not very clear regarding it, and only the patients who have that mutation positive are able to receive osimertinib, not all of them. Next slide. You actually already discussed. Next slide. Yeah, so we've discussed this part. So the last final word I would like to say is that post osimertinib, many a times there is a little debate as to what should we do post osimertinib. There, one would like to really note that post osimertinib there's no clear cut indication to give any TKI at this moment. There are studies to suggest that one should do an NGS testing to find out whether there is any mutation in the form of C797S in the EGFR domain, or the MET amplification or the HER2 amplification. But there are trials going on, but there is not something concrete which is standard of care. Mostly one would resort to chemotherapy. But then in times to come, once we decipher as to post osimertinib what we have to do in terms of our oncogenic driver mutations, it will become more clear to us as to how to really sequence these EGFR TKIs in our practice. So with this, I thank the organizers for having me here, and back to Dr. Manish. Thank you.
Thank you, Dr. Rajat, for such a nice and crisp presentation. So, just one question. So, do you treat your L858R patients and exon 19 differently, or you treat them in the same way?
No, so right now I'm treating them in a similar way, although I do understand that, I completely am convinced that there is a difference. The L858R patients will not do as well as DEL19, but that is true for all the treatment options which are available. There is data to suggest that the overall survival is better with dacometinib in L858R, but then probably the trials were designed in that way. Flora, also the PFS, if we see in Flora L858R PFS, the patients benefited with osimertinib compared to first generation TKI. So as of now, I give the option of osimertinib to my patients of DEL19 as well as exon 21 mutations.
So is this a patient subset where we can go for dacometinib or ramucirumab followed by osimertinib, or still you just wish to go with osimertinib in all your patients?
So when we're talking about L858R patients, we have data to suggest that we can give the option of the relay study or the Archer study to these patients. I'll be more confident offering this particular option to the exon 21 patients compared to DEL19, but that doesn't take away the fact that exon 21 patients will not respond to osimertinib.
Thank you so much for your being here, and please stay with us for the panel discussion. I think Dr. Jyoti is here. Good evening, Dr. Jyoti ma'am.
Good evening, Dr. Manish.
So the next topic would be taken by Dr. Jyoti, and she is a senior consultant in Yashoda Hospital, New Delhi. She will be speaking on current advances of targeted therapy in NSCLC. So Dr. Rajat has spoken about EGFR, and she would be speaking on all other different mutations which we can come across.
Yes. Thank you, Dr. Manish, for having me here. So today I have been given a difficult topic, I would say, and a rare thing also. So emerging predictive biomarkers for targeted therapies in NSCLC, something beyond EGFR also. So one is HER2 positivity. Though it is very rare, HER2 overexpression we can see in 23% of non-small cell lung cancers, with 3+ expression in 4% only. Amplification we can see in approximately 7% of the patient, they can have high amplification, and followed by HER2 mutations, which is 2.6% patients, they can have HER2 mutations, and it is more common in never smokers. So actionable target is PAN or B TKs with efficacy, which is balanced by wild type EGFR toxicity. So characteristics of HER2 2+ cohort and HER2 negative cohort, males and males versus females. Obviously HER2 positive cohort, they had lesser number of patients as compared to HER2 negative cohort, but the percentage was same, around 41% versus 46%. Median age was 62, 61, and we all know that stage 4 cancers are more common, and they're talking about metastatic disease. So most of the patients, they had a stage 4 disease. And out of tobacco use, 70% they were never smokers in the HER2 positive cohort. So seeing the incidence is more of HER2 amplification in never smokers as compared to HER2 negative cohort, which were more of them, 60% of them were former smokers. So talking about HER2 TKs in HER2 mutant advanced lung cancer, it was a retrospective analysis of fefartinib, which is a pan-HER TKI in HER2 mutant advanced lung cancer. The overall response rate was 13%, and the median treatment duration was 3 months. And change in tumor size was seen from baseline. So around 50 to 60% of the patients, they had partial responses. And if you see with dacometinib, it is a phase 2 prospective trial, which is also a second generation pan-HER2 TKI in HER2 mutant or amplified advanced lung cancer. Overall response rate was 12% in mutant and 0% in HER2 amplified. And according to change in tumor size from baseline, it is around also almost the same, around 60% of the patient, they had tumor responses of those patients who had HER2 mutation. So now coming to Destiny Lung 01, it is a trial with trastuzumab deruxtecan in metastatic non-small cell lung cancer with HER2 aberrations. It was a multi-cohort phase 2 trial, which is a prospective study. And it was patients who were included were unresectable, metastatic, non-squamous non-small cell lung cancer, relapsed refractory to standard therapy, HER2 overexpressing or with the activating mutation. Sorry, no previous HER2 targeted therapy was given to such patients. ECOG PS of 0 to 1. They were divided into 2 cohorts, overexpressing and mutated, and they were given trastuzumab deruxtecan with a dose of 6.4 milligram per kg. IBQ3 weekly. Primary endpoints were confirmed overall response rate. And if you see overall response rate, it was 61.9%, and disease control rates were to the tune of 90.5% in patients who received trastuzumab deruxtecan. And seeing this PFS, it was around 14 months of PFS was seen, and median follow-up of 8 months was there. Again, efficacy, changes in tumor size according to the HER2 positivity 2+ or 3+. 2+ people were also doing well, and in them also the response rate were good, around 90%, and median duration of response was 6 months. And this was the median PFS of approximately 5.4 months in HER2 overexpressing patients. So response to trastuzumab deruxtecan in HER2 overexpressing non-small cell lung cancer by baseline IHC status, 3+ overall response rate is 20%, 2+ 25.6%, overall it is 24.5%. And if you see, disease control rates were 80% in patients who had 3+ HER2 positivity, and in 2+ it is 66.7%, though the median duration of response was 6 versus 5.8 months, which is almost same. Talking about toxicities of trastuzumab deruxtecan, more than 80% of the patient, they had nausea, nausea, followed by alopecia, anemia. One more bothering side effect was low TLC, which was seen in around 25 to 30% of the patients, or diarrhea, which was more than 30, diarrhea and vomiting, which was 30 to 40% of the patient. This is more patient who had more than equal to 3 treatment-related adverse events were 55% of the patient that suffered grade more than 3 side effects, which can be decreased neutrophil count in more than 15%, pneumonitis in 5%, associated with dose reduction, the decreased neutrophil count, fatigue, nausea, dose interruption. Neutrophil count was the main cause for dose interruption, and drug-related toxicity of grade 5 was seen in 7% of the patient, 14.3% of the patients. So pneumonitis, grade of pneumonitis according to HER2 overexpressing non-small cell lung cancer, most of them had grade 1 or grade 2. Only 6% of the patient had grade 5 toxicity, and any grade was seen in 16.3% of the patient. So 11.9% of HER2 mutant and 16.3% of the HER2 overexpressing patient, they suffered pneumonitis. Targeting HER2 in non-small cell lung cancer, HER2 overexpression was not as strong a predictive biomarker. No FDA approvals of targeted therapy for HER2 mutant non-small cell lung cancer. Poziotinib granted FDA fast track designation March 2021. NCCN guidelines now include TDM1 and trastuzumab deruxtecan for the treatment of patients with non-small cell lung cancer and HER2 mutations. Now coming to KRAS, activating KRAS mutations are commoner as compared to HER2. It is 25% of the patient. They are usually smokers, adenocarcinomas, and so it is less common in Asian population. It is a challenging target because it has many central pathways, PIK3, RAF, MEK, so very number of escape pathways are there. Variety of KRAS mutations are there, but G12C, approximately 13% of the lung adenocarcinomas patients, they had G12C KRAS mutation. CodeBreaK 100 study of sotorasib in KRAS G12C positive non-small cell lung cancer. It was an phase 1, phase 2 trial, which is a direct sotorasib, which is a direct KRAS G12C inhibitor, and patients who had locally advanced or metastatic non-small cell lung cancer with KRAS G12C mutation and progressive disease and prior standard therapy were included, and brain metastases were excluded with a dose of 960 milligram orally daily until progressive disease, and primary endpoint was overall response rate. And if you see, most of the patients, they had received platinum-based chemotherapy plus minus immunotherapy, approximately 81% of the patients, and majority had a smoking history. They were pre-treated. Disease control rates was good. It was 80.6% of the patient, they had disease control rates with confirmed ORR was seen in 37.1% of the patients. So this is the durability of response. Good. Median duration of response was 10 months. Median treatment duration was 1.4 months. Disease control rate was 80.6%, and median PFS was 6.8 months. So good safety profile of this drug, sotorasib, any grade, it is 69.8%. Diarrhea was around 30%, which is, I think, class effect with TKIs. And nausea, ALT, AST increase, fatigue, vomiting. These were the any grade toxicities. If you see grade 3 toxicities, it was only in 19.8% of the patients, and diarrhea was only in 4% of the patients. So it exhibited a good safety profile. Coming to next drug for KRAS G12C, it is adagrasib. It was again non-randomized open label phase 1, phase 2 study. Current analysis in 79 patients in non-small cell lung cancer. And here patients had treated or stable brain metastasis. They were included. They were not totally excluded. This was the dose escalation followed by monotherapy of 600 milligram BD. It was phase 2. And primary endpoint was overall response rate. And majority of the patients, they had a smoking history and they were pre-treated. 92% they received prior immunotherapy as per current guidelines. All the patients, I think, are receiving chemoimmunotherapy or immunotherapy according to PD-L1 status. So response with adagrasib, 43% is the overall response rate in phase 1, phase 1B. And in phase 1 and 1B and 2, it is 45%. Disease control rates were 100% or 96% in phase 2 study also. Depth of response, we have seen it is more than 96%. The patients were having good response rates or tumor reduction. And this orange bar is for phase 2 study, patients who were experienced good tumor shrinkage. Durability of response, it is median duration of response was 8.2 months for patients who were treated with adagrasib. And safety profile, which is important, at 2 patients with the grade 5 treatment-related adverse event, which was pneumonitis, recurrent pneumonitis, or cardiac failure. These were the side effects which were life-threatening. 4.5% of the treatment-related adverse event led to discontinuation. So targeting KRAS G12C non-small cell lung cancer, their inhibitors are effective. Overall response rate of 40% for both the drugs, well tolerated, good safety profile. Overall response rate lower than some other targeted agents, for example, EGFR or LTK. In previously treated non-small cell lung cancer, current standard of care is docetaxel plus ramucirumab with overall response rate is 23%. Appropriate for first-line use, studies are still ongoing. Combination studies are ongoing, and other KRAS inhibitors are still in development. Now coming to...
Ma'am, great talk, but another 3 minutes to close.
Sure. Now coming to EGFR exon 20 insertions, exon del19 and L858R mutations are well taken by Dr. Rajat. So osimertinib in exon 20 mutations, overall response rate was 24%, disease control rate was 82%, median PFS of 9.6 months. But most common toxicity was diarrhea. 76% of the patient they had diarrhea, and 30 to 40% of the patient they had rash also. So CRs were also seen here. And these were this is the trial for mobocertinib, which is in advanced NSCLC with the EGFR exon 20 insertion. I will not go into detail. So best tumor responses, more than good number of patients, they had partial responses with this drug also, even in platinum pre-treated patients. And talking about the side effect profile, 90% of the patient they suffered diarrhea, 92% of the patient they suffered diarrhea, followed by rash, which is in 40-45% of the patient. So TKI with efficacy in EGFR exon 20 insertion in non-small cell lung cancer. Notable toxicity related to wild type EGFR activity, 25% acquired dose reduction, 17% required treatment discontinuation. Now coming to Chrysalis study, which is amivantamab for EGFR exon 20 mutations in a dose of 1400 milligram day 1, day 8, then Q2 weekly. All patients they had progressed on chemotherapy, and a quarter had progressed on prior EGFR TKI therapy. History of brain metastasis, patients were included. Median prior lines it was 2. So this is near loop region was a exon 20 location where the patients were most benefited. Median PFS was 8.3 months. Median duration of response was 11 months, and 40% of the overall response rate was there. And the safety profile, rash was common but mild. Diarrhea was not common. So amivantanab granted FDA breakthrough therapy designation in March 2020. So for targeting EGFR exon 20 insertions, we have mobocertinib. Diarrhea is the bothersome side effect. Amivantanab, rash, osimertinib, diarrhea, Ozotenib, diarrhea and rash, and this is one CLN-081, rash in 60% of patients. So conclusions are novel biomarkers and targeted agents are emerging quickly. HER2 mutations, overexpression, TDM1 and trastuzumab deruxtecan are now included in NCCN guidelines. Higher overall response rate, but potential for pneumonitis. KRAS mutations, inhibitors are in development, sotorasib and adagrasib. Frontline combinations are still under investigations. For EGFR exon 20 insertion, mobocertinib and amivantanab with FDA breakthrough therapy designation. Broad testing is increasingly relevant. I finished my talk here. Thank you organizers for inviting me.
Thank you, ma'am, for completing well in time. Dr. Manish, you are there. Any questions for Dr. Jyoti? Dr. Rajat? Dr. Manish, can you hear us? So, Dr. Manish, can you hear us? Ma'am has just finished an excellent talk. Any questions for ma'am?
Yeah, so actually, my laptop battery has exhausted. So I have joined from my mobile. So Dr. Jyoti, this was actually a very broad topic. Very, very, very difficult to cover in just 20 minutes time,
Yes.
but you did an excellent job. So I have a question, whether you are doing sequential testing or you have started doing NGS for all your patients?
I have started broad testing.
So broad testing would mean both DNA and RNA sequencing.
RNA.
Both DNA
Mean-
and RNA.
Yes, yes.
But do you feel that there are sometimes some of the issues with NGS because it takes so much of time and the cost is quite high?
Cost is definitely high, but I think many of the companies like Novartis and now Merck also came because they are coming up with the one MET inhibitor. So they are giving kind of a support to patients, getting it in less price. But regarding I don't know, regarding the efficacy, I cannot say. But yes, the cost is definitely much.
So I think in the times to go, once you have these treatments available, it is important to go ahead with NGS in all of our sessions.
Sorry, Dr. Manish, your voice was not clear.
I think Dr. Manish has lost the connection, and sir, I think you're on the 2 device. If you can, close one device, that will be great.
Yes. Actually, my battery just ran off. So I will be speaking on the real world evidence on.
Yeah, really. So the next topic is the real world evidence of osimertinib in treatment of EGFR mutant NSCLC. So over to you, Dr. Manish, for your talk, and you have another 20 minutes to go, sir.
I think my slides are visible and they are moving, right?
No, we can't see your slides.
No, sir.
Can you share
I've
it
shared
again?
my screen.
So you're sharing your screen, but if you can just again, yeah, now we can see the slides, sir. Very nice. All yours.
So good evening all, thank you so much. And it is very important that we should know about the real world evidence also on whatever drug we are using, because the reason being whenever we are using the drug, they are being tested in the very, very controlled setting, and real world evidence from osimertinib is here, and we will be sharing this real world evidence on osimertinib. So in the patients with EGFR mutation, the PFS improvement is there as compared to the cytotoxic chemotherapy. We all know that we have been discussing about osimertinib in the FLORA trial by the previous speakers, so I will not go into the detail about that. Overall survival with osimertinib is 38.6 months versus 31.8 months with chemotherapy, and hazard ratio is 0.80. So this is the best treatment option at the moment available with us in EGFR mutant lung cancer. So this is the FLORA trial. The previous speaker has already gone through that. These are the baseline characteristic primary analysis about the progression-free survival in the FLORA trial. Dr. Rajat very well spoke about these Kaplan-Meier curves separating early from the treatment was initiated. So this is now the 3-year benchmark, and 10% more patients they are surviving as compared to the chemotherapeutic agent in EGFR mutant lung cancer. So these were the conclusions. Will not go into the detail. So this is the category 1 indication at the moment about osimertinib in EGFR mutant lung cancer, whether it is squamous cell carcinoma or adenocarcinoma. In both of them, EGFR mutant, osimertinib is the category 1 and preferred choice by NCCN. So talking about the real world evidence about osimertinib, there are 3 studies: FLOWER study, OCFACT study, and the MYKONOS study. We will be speaking about all these 3 studies. The first line osimertinib study, this is the FLOWER study. First line osimertinib in patients with EGFR mutant advanced non-small cell lung cancer. So this is an irreversible TKI, and it has proven its will in phase 3 FLORA trial. Overall survival is 36.6 months. But the real world data has become a very, very important tool to assess the unique insight in the routine oncology practice in the post-marketing setting. So these are the key features in this FLOWER study. Most of the patients, the median age was 68 years, and in 30% of the patient, brain metastasis was present. Stage 4B, so the highest stage patients, they were 71% in this clinical study. So usually you don't find so many patients of stage 4 in the FLORA trial, but the real world study, 70% of the patients they had stage 4B. So these were the inclusion and exclusion criteria. Any patient who had received study drug in clinical trial was excluded. Those patients who were more than 18 years of age, diagnosis confirmed, EGFR mutant, exon 18, exon 21, locally advanced stage 4, they were included, and they were eligible to receive first line osimertinib as a 3rd generation oral TKI. So the median time to time to treatment, second treatment, was measured from the osimertinib start to the discontinuation because of the any cause. So this was the primary study endpoint, median time to treatment discontinuation, and the rate of treatment related adverse event and rate of dose reduction and temporary or definite treatment interruption. So these were the 3 major endpoints, primary endpoint, and the secondary endpoint were overall survival, PFS, response rates, disease control rate, and the very important was the diagnostic therapeutic pathway. What is the time frame between the diagnostic biopsies and histological report that has been used by the various real world physicians, the proportion of patients undergoing loco-regional treatment, type, frequency, and re-biopsy performed at progression. So this was the primary assessment of the effectiveness. The outcomes, they were similar to the published data, and thus adding the consistency to the osimertinib efficacy. There was no difference in progression-free survival, time to treatment discontinuation, overall survival in the elderly patients and the patients with comorbidity and less common EGFR mutation. So in the real world scenario also, this drug worked well as the FLORA study. So if you see the different subgroups were whether the patient had symptoms or no symptoms, and time to treatment discontinuation was more if patient did not have any kind of symptom. So you can see here that the time to treatment discontinuation was not reached versus 18.8 months if the patient had symptoms. Similarly, less than 3 or more than 3 metastatic sites. So if patient had less than 3 metastatic sites, the time to treatment discontinuation did not reach this median till now. While if the patient had more than 3 metastatic sites, the time to treatment progression was 21.4 months. So these are two adverse biological factors which we can say. So patients with poor PS, comorbidities, rare EGFR mutation and active brain metastasis, they were included, and the active brain metastasis patient, they were excluded in FLORA trial, please do remember that, and the outcome, they were similar to the published data. Time to treatment discontinuation appears to be a more suitable primary endpoint to evaluate the treatment outcome, and this was longer than the post-progression outcome analysis of the FLORA trial. The better TTD was associated with fewer than 3 progressing sites and isolated progression compared to the systemic progression. So this we have already spoken. If patient had symptoms present or not present, those patients who had symptoms, they had less time to treatment discontinuation as compared to those patients who had more of this thing. Similarly, if the patient had less than 3 metastatic sites or more than 3 metastatic sites, less than 3 metastatic sites, patients, they seem to do better as compared to those patients who had more than 3 metastatic sites. Similarly, if the brain metastases were present metastasis, not the treated brain metastasis, those tend to do worse as compared to the patients who had active brain metastasis. So these were the CR, PR rates and stable disease rates. CR rates were 0%, PR rates were 73%, stable disease rates were 23%, and progressive disease was seen in 4% at 12.3 months of PFS. Sorry, 18.9 months of PFS at the median follow-up of 12.3 months. So this we have discussed. So diagnostic pathway, this was another secondary endpoint, and the essential element of the evidence-based medicine could help clinicians in decision making. Amongst patients experiencing progressive disease, 47.7% the patients, they underwent re-biopsy at progression. So in our clinical practice also, once the patient progresses on osimertinib or first generation or second generation TKI, we do re-biopsy these patients, and in the real world also 47% patient underwent repeat biopsy. Tissue rebiopsy 66%, and the liquid biopsy was done in 28.6% patients. Molecular analysis was performed in 61.9% patients, and druggable resistant mechanism included MET amplification in few patients, MET amplification, EGFR amplification, and HER2/neu amplification. Safety data, it was similar. So you can see that patients had ILD. Any grade ILD was seen in 9.5% patient, diarrhea 38.9% patients, rash 33% patient, dry skin 19% patient. And one important thing to note is that the patients can have venous thromboembolism, and good number of patients, 10% patient had venous thromboembolism, out of which 7.9% patient, they had grade 3 or 4 venous embolism. So whenever you are giving osimertinib in the real world setting, please do consider venous thromboembolism as one of the factor if patient presents with breathlessness. So venous thromboembolism was most common. In the real world ASTRACE study, grade 3 embolism occurred only for 2% of the patient, but here grade 3 for venous thromboembolism occurred in 7.9% patient. No difference in rates of venous thromboembolism was reported according to the age, PS, comorbidity or tumor load. So you can see here that none of the PS, age or comorbidity or tumor load was associated with the increased rate of venous thromboembolism. So this was another study, OC-FACT study, osimertinib as a first-line treatment for advanced epidermal growth factor receptor mutation, non-small cell lung cancer in the real-world setting. So this is the introduction as the previous one. These were the inclusion and exclusion criteria. Inclusion criteria was EGFR mutant NSCLC with osimertinib as the initial treatment, and exclusion criteria patient concurrently using other anti-cancer drug or undergoing thoracic radiography, undergoing post-operative adjuvant chemotherapy, or receiving osimertinib as a second-line treatment option. These were the baseline clinical characteristics. So efficacy endpoint, the the PFS events occurred in 182 out of 538 patients, and median PFS was recorded was 20.5 months. You can see here. So what are the significant parameters that was associated with the PFS? So being male, malignant pleural effusion, liver metastasis, and advanced unresectable cases, these were associated with poorer prognosis. So these were significantly associated with PFS, and you can see that the hazard ratios were 1.99, 1.51. Liver metastasis hazard ratio was 1.55, and advanced unresectable disease was 1.71. So although the PFS was 20.5 months, but these were the factors which were associated with the poorer prognosis in the real world study. And with respect to PDL1 expression, those patients who had TPS of 1%, the median PFS was not reached. With TPS of less than 49%, 1 to 49%, 14.7 months. With TPS of 50%, 11.1 month. So this we have discussed in previous slide. Male, malignant pleural effusions, liver metastasis, stage 4 heavy burden disease, and TPS of more than 50%, they were associated with the poorer outcome in the PFS in these patients. So what were the reasons for treatment discontinuation? So please see here that 25% patient discontinued treatment because of the pneumonitis, which we generally forget to see. So 25%, 1/4 of the patient in this real world study had pneumonitis and treatment discontinuation. The reason for treatment discontinuation. Other were anorexia, skin disorder, which was the most common, cardiac failure in 4 patients, QT prolongation, 3% patients. These were the other reasons which were there for treatment discontinuation. So major reason was the pneumonitis. So all grade pneumonitis occurred in 12.8% patient, and grade 3 and 4 pneumonitis occurred in 5% patients. Hematological toxicity, grade 3 or 4, 4.3 and 11.2% patient. Prolonged QT interval, 4.1% patients. So this was the conclusion. Overall response rate was 76.2%, and disease control rate was 94.1%. PFS is better with osimertinib than with conventional EGFR TKI. Median TTF was 19.1 month, and median time from start of treatment to the onset of adverse event was 56 days. Pneumonitis of all grade occurred in 12.8% patient. Grade 3 or higher pneumonitis occurred in 5% patients. And conclusion was the PFS was after first line osimertinib treatment in real world practice was favorable. And the discontinuation rate due to adverse event 41%, especially pneumonitis, occurred, requires further investigation. So this is another real world study of patient with EGFR mutated locally advanced metastatic NSCLC treated with first line osimertinib. This is the background. So background says the similar thing as that of the previous study. There remains a need to evaluate real world clinical characteristics and clinical outcomes in patients with EGFR mutant first line osimertinib monotherapy. So the study reported the demography, clinical characteristic, and real world time to patients with advanced EGFR mutant NSCLC who received first line osimertinib in the US. So I will
Hello, Dr. Manish, sir.
I think he has a very unstable this thing.
Network, right, sir.
Hello, Dr. Manish, can you just stop or? Yeah, Dr. Manish, your
Patient
I think-
listening.
thank you. So I think, Dr. Manish, thank you so much for the talk, and most of the question I think would be taken by Dr. Praveen Jain, sir. Dr. Praveen Jain is already there. Hello, good evening, Dr. Praveen Jain, sir. Thank you so much for joining, and we would like to introduce you. So Dr. Praveen Jain is the head of the Department Medical Oncology at Akash Healthcare, Delhi. Can you allow Dr. Praveen Jain to share the screen, Ankit?
Dr. Praveen, good evening.
Good evening, Dr. Manish.
Sir, over to you. Dr. Praveen Jain, sir, over to you. So we have Dr. Abhishek Yadav, the consultant and unit head medical oncology at Yashoda Hospital. We have Dr. Rajat Bajaj, senior consultant from Fortis Noida. We have Dr. Sajna, a consultant medical oncologist from prestigious Rajiv Gandhi Cancer Institute. And of course, we have the expert, Dr. Manish Sharma, who is also with you. So all yours, sir, the floor is set for you for the panel discussion.
So thank you. So first of all, thank you, Dr. Manish, for giving me this opportunity. And we are here. So after we have discussed the management of EGFR mutated advanced non-small cell lung cancer. So I think it is very, very important to discuss the early stage lung cancer patient also, because nowadays we are getting almost 40% of these cancers with non-small cell lung cancer. So they present in early stage, and we already know that the early stage lung cancer, it's an unmet need, and most of the patients, majority of the patients, they have relapse at some point of time. And if we see stage 1, B, stage 2, stage 3, so these are those high risk non-small cell lung cancer patients. So where chemotherapy has made some improvement in the outcome, and the overall survival advantage which is seen with the chemotherapy is close to 5%. So but now, because the precision medicine has come into picture for all type of cancers, and for lung cancer, so maximum number of molecules are available nowadays. So I think early stage lung cancer patient also should be given this benefit. And so recently there were a lot of trials with the first generation TKI, EGFR TKI, and the third generation EGFR TKI in the adjuvant setting. And they have shown good amount of improvement in the progression-free survival, but unfortunately none of the trial has shown any overall survival advantage till now. So I think we will just discuss all these aspects in this panel discussion. I hope all of my panelists, they have joined. Dr. Abhishek Yadav, are you here? So Dr. Abhishek.
Yes, sir. Good evening.
Good evening, Dr. Abhishek. So Dr. Rajat Bajaj.
रजत की ओपीडी 9 बजे तक चलती है सर.
So Dr. Manish obviously is here. Dr. Priyanshu and Dr. Srijna.
Hi, sir. Good evening.
Hi, good evening, Priyanshu. And Dr. Srijna, are you here? And if I have missed someone, please tell me if any more panelists are there, because I did not get the list of the panelists. So I think we will start off with a case. So this case has been given to me by AstraZeneca people, and so it's a hypothetical case probably. So 67-year-old gentleman, non-smoker, presented with mild cough, and patient was evaluated by a general physician for the same, and chest X-ray showed a small lesion in left upper lobe, and the patient underwent CT scan of the chest, which confirmed the finding of chest X-ray, and there was this lesion in the left upper lobe. So this is a CT scan with contrast, and we can see here, so the lesion is close to, I think, 2.5 or 3 centimeter in size. So this is the PET CT finding, that intensely FDG avid well-defined lobulated soft tissue nodular lesion in apico-posterior segment of left upper lobe with adjacent pleural tags. So apart from that, there is a prevascular lymph node which is non-avid, could be non-specific, could be reactive. So at this point of time, the biopsy was done from the lung lesion and it came out to be adenocarcinoma of the lung. So I would like to ask the panelists. So this was a small tumor in the left apical lobe. So does all of these patients, they require biopsy prior to going ahead with any sort of treatment? I think we'll start with Dr. Abhishek. So in your clinical practice, do you proceed with biopsy in all the patients, or you discuss in the multidisciplinary tumor board and then you decide about it?
So if the lesion is very, very highly likely on imaging to be malignant one, then I don't think we need a biopsy.
Okay. So like this lesion, so it's a speculated lesion, probably 2.53 centimeter. We cannot call it a peripheral lesion because it doesn't fit into the definition of peripheral lesion. So this lesion, would you consider the biopsy? And there is a normal lung parenchyma which is around this lesion throughout. And if you do a biopsy for this lesion, you will be puncturing the normal lung. There are about 3 to 5% of chances of developing pneumothorax because of the biopsy. Are you willing to take this risk of developing pneumothorax, or you are directly going to proceed for surgery in this patient?
So usually the patient comes to us after coming through a pulmonologist or after a consultation with an MD medicine. So usually we see an FNAC or biopsy has already been done.
So most of the time this is the scenario. So Dr. Priyanshu, in your clinical practice, do you proceed with biopsy in all the patients?
Sir, as Dr. Abhishek rightly said that a lot of patients do come to us with a histopathological diagnosis. At least they do an FNAC or something like that. But if the patient comes to me upfront,
So, Priyanshu, are you there?
Which is highly suggestive of malignant mass. Then definitely not required. We'll discuss in a MDT team for surgery if possible.
Yes. So this patient, would you consider for mediastinal staging? So there is a non-avid prevascular lymph node which is there on the PET CT scan, and we know that PET CT scan with a lesion of less than 1 centimeter avidity might not be there, and the sensitivity of PET CT showing a PET avid lesion in less than 1 centimeter is quite low. So would you consider this as a negative lymph node and negative mediastinum, and you proceed with the radical treatment upfront, or you will do some sort of mediastinal staging for this patient?
I'll go with the mediastinal staging, EBUS or in US, and plus TBNA, and then go for surgery after that.
So I think the guideline also says a similar thing, that if a lesion is more than 2 centimeter, if it is a central lesion, and if there are any sort of lymph node which are available on the CT scan or PET CT scan, so it is prudent to go ahead with mediastinal staging and to prove whether if mediastinum is negative or positive before proceeding to some radical treatment. So this patient also, one second. So the question again is the tissue sampling technique. So this patient with a lesion which is in between, so both the options are there. You can go through the transthoracic approach also, and you can go through the bronchoscopic approach also. So Manish, your choice of technique for biopsy. I know we do not have any interventional radiologist or a chest physician in our panel, but so what will be your approach here?
approach for the biopsy from the primary or US or
Primary,
this-
primary. So we are talking for primary. This lesion is central lesion, 3 centimeter. You have to go ahead with a biopsy upfront before proceeding with the.
I think US and navigation biopsy can be done for this patient.
Is it available in RGCI Nitibag?
Yes. No, not available in RGCI, but we constantly.
So then that
replicate
patient will
with Rohini.
become the patient of RGCI Rohini.
So navigational biopsy is available and we can do that. Apart from that, for mediastinal EBUS as mentioned by Dr. Priyanshu, but this patient has a prevascular lymph node which is not accessible by EBUS. For that,
That is the important thing. That is the so it is it can be accessed. The prevascular lymph node also can be accessed, but you will have to go transaortic.
But
So,
it becomes quite dangerous for the intervention person to do that.
Yes. So as rightly, so there are two methods of doing biopsy. One is the central method, which is bronchoscopic guided, and the navigation protocols. They are very well developed nowadays, and they are able to. So respiratory physicians, they are able to get to the third order bronchus to get the biopsy from these lesions. And these are relatively safer method as compared to transthoracic approach, but the amount of tissue which you get with these bronchoscopic approaches, so these are not very high. And in lung, we know even in early stage non-small cell lung cancer, here our motive is just to get the diagnosis. But in metastatic cancers, in advanced non-small cell lung cancer, we do have to look for the molecular abrasions also. So we need to have a good chunk of tissue, and there probably one can go towards transthoracic approach. So would you recommend brain MRI or CT scan at baseline?
Yes, for all of my patients, I do that. But considering that this is a very, very small lesion, it may be skipped as per NCCN guidelines. But all of my patients, because it costs somewhere around 6,000-7,000 rupees, we do brain MRI for all of my patients.
Okay. So this we have already discussed, the mediastinal staging. Then is getting tissue sample or biopsy a challenge in early stage lung cancer? So yes, it is definitely a challenge, and we have already discussed regarding the approaches. And we can see over here that the stage 1A tumor, those less than 2 centimeter peripheral lesion. So there we can definitely avoid mediastinoscopy also and the MRI also. But stage 1B onwards, so we have to do a pathological mediastinal lymph node evaluation also and the brain MRI also. So this patient underwent US, and there were no enlarged mediastinal lymph node which were seen on US, and patient was medically fit, underwent surgery. So any taker of any neoadjuvant therapy for this patient? So Priyanshu.
The neoadjuvant actually is not the standard of care. Probably, you can use it when you have, a bulky disease or a new single station N2 disease, or, in Pancoast tumors. That is where you can use. Otherwise, or probably, like we had in a government setup when you were not getting dates for surgery or probably a radiation also, to buy time and, start something. Otherwise, at least not in this patient. He's fit and he doesn't have any mediastinal nodes, and you can upfront go for surgery.
Yes. So this patient underwent surgery, and the final pathology, the pathologic staging was PT2N1, and there were no extranodal extension. And the margins were all negative, and it was moderately differentiated tumor, and the size of the tumor was 2.9 into 2.5 into 2 centimeter. So practically it's a stage 2 disease. So now what next? So Abhishek, so what do you do? So in your practice, do you really go ahead with biomarker testing in all the patients? Dr. Abhishek, are you here? So Dr. Manish.
Yes, sir. He is available.
He's available. I think his mic is switched off. Abhishek, can you unmute yourself?
तो उनका मैसेज भी आया अभी.
अंकित आप अपनी साइड से म्यूट कर दो, अनम्यूट कर दो ने.
So I think Dr. Manish, you can take up this question. So in your clinical practice, do you go ahead with biomarker testing in all patients?
So till few months back, I would say we were not doing that because none of the clinical trials in the adjuvant setting for these biomarkers, they had shown overall survival advantage. There are plenty of clinical trials with other drugs like gefitinib and erlotinib. But from now onwards, we have started doing these markers like EGFR, ALK and PD-L1. We are doing multi-gene panel testing for all of our patients nowadays.
Okay. And you are doing multi-gene panels. So that means that covers EGFR, ALK, ROS, PD-L1, everything.
Yeah, I understand that we don't have treatment option for ALK or ROS or MET at the moment. We don't have any data to suggest that we can use it in the adjuvant setting, but still at least for the research purpose or for the future use, we have started doing that. And you need a lesser tissue rather than doing specific markers than the multi-gene panel.
Okay. So Priyanshu, so what will be the appropriate sample for doing this testing? So there are two type of tissues which are mentioned over here, but I would like to ask regarding the liquid biopsy also. So are you going to use the pre-surgical tissue or the post-surgical tissue or the liquid biopsy or a combination of any of these?
Sir, if there's no neoadjuvant given, I don't think there's any difference between pre and post, but I definitely prefer biopsy specimen, the first one. And I do EGFR and PD-L1 only. I'm not doing any other marker as of now. And liquid biopsy, I've not used as of now. And the sensitivity would be a little bit less than tissue sample in a liquid biopsy. And I think so. And it all depends upon what are you planning. If the patient is not affording for, adjuvant osimertinib, you even might skip testing these mutations.
We will talk about science. So leave affordability aside. So if Priyanshu,
but in practical settings, sir, a lot depends upon affordability.
So this patient is a metastatic patient.
Okay.
And now you have to do multi-gene panel. So what tissue are you going to use? So are you going to use a biopsy specimen, tissue specimen, or a liquid biopsy, or a combination of these?
No, a biopsy specimen is enough, sir, for NGS, I guess. Liquid biopsy, I'm not doing upfront unless you don't have a viable tissue.
Okay. So, Dr. Srijna, I'm sure you're here.
Yes, sir.
So, RGCI, it is hub of these molecular pathology. So what is your take on this? So whether you are going ahead with a tissue biopsy or a tissue biopsy plus liquid biopsy or only liquid biopsy in a metastatic patient. So early stage, I think still means the world will go ahead with a tissue biopsy only. So, but what is your take on the patient with a metastatic disease?
Sir, if the patient is sick and is not fit for doing a tissue diagnosis,
Patient is
in ICU.
PS1 no affordability issues. He says that whatever you want to do, you do. I just want to skip chemotherapy.
So if
this
the
kind of
finance
patient
is not an
usually-
issue, we'll get both a liquid biopsy and a tissue biopsy. And on liquid biopsy, I would like to do EGFR testing, and for the tissue biopsy, I would order for the multi-gene panel testing.
Okay. So South Delhi, Dr. Saab, so means this sort of patient comes to you, so who says, I have a big house in South Delhi and I can just sell off a part of it and you do whatever you want to do. But I'm very skeptical of taking chemotherapy.
So you are asking whether you should be going ahead with both the test or single test.
Yes.
So if single test is positive, then no need of doing second test.
And if it is negative?
Then the other test should be done.
Okay. So this is the right approach. And there was a Niles study which showed that if you combine both the tests together, there are approximately 28 to 30% more tests which comes out to be positive. And in fact, if you use liquid biopsy first, and if liquid biopsy is negative and after that you do the tissue biopsy NGS, so it is more fruitful to do this approach rather than tissue biopsy followed by liquid biopsy. So please go through this article, and I think we will stick to the case now. So what biomarkers, Srijna, will you be doing in this patient? Early stage lung cancer, non-smoker, and the patient is 67, doesn't want any chemotherapy.
So, sir, in our hospital, we have the multi-gene panel testing. So, ideally, as per the evidence for the drug targets available, we have only the EGFR and PDL1 targets, if at all they become positive in the adjuvant setting. Otherwise, if it is in a multi-genal panel testing, I would go for EGFR, I'll cross PDL1.
Okay. So I think this is the standard of care. So we have therapies available for EGFR and the PDL1. We have first generation to third generation TKI, which can be given in the adjuvant setting. And we do have Atezo, Pembro, which can be given in the adjuvant setting with the PDL1 positive. So I think we will not take up this question and we will straight away move to. So now this patient, it's a T2N1, and I think the consensus will be that there is no role of radiotherapy here. But if this patient would have been a PT2N2, so Dr. Priyanshu, would you consider radiotherapy in this patient in that case?
So the lung ART trial has not shown any benefit of adjuvant RT in adequately resected. Only, yes, definitely, there are some guidelines which recommend adjuvant CTRT actually if you have a nodal disease. But in my practice, I'm not giving post adjuvant RT except for margin positive. That's it.
No, but will you be considering port in some patients who are N2 post-operatively? So are there any group of patients where you will consider RT? Leave aside the margin positive status. Leave aside those.
Yes, sir. N2 disease, I do, consult with our, radiation colleague for that, because although, I don't think that the recent data is beneficial, but there are difference in opinion in certain guidelines. I mean, ASCO and NCCN and even the American, pulmonologist also have a different version of this. So the guidelines might suggest some guidelines might suggest the post-operative RT, but in my practice, I'm not giving even in N2 disease.
So I think it's very important to consider that the previous trials which were done for the post-operative RT, so there the surgical technique was not that advanced. So now we are able to do the surgery with good amount of techniques. So VATS is there. Hanji.
Which theater for your radiation? what kind of N2 patients do you consider for radiation, or you do not give any radiation to these N2 patients?
That's what I'm telling you, that previously whatever trials were there of the adjuvant RT, so it was never like there were dichotomy in the thought process regarding the adjuvant RT. So there was one set of trials which showed a small amount of benefit with the adjuvant RT if the patient is a pathological N2. But there were another set of trial which did not show this benefit in the outcome of the patient. So I think since then, so the surgical techniques have also improved, and the chances of side effect with RT also has reduced. So that was the reason why this adjuvant RT trial, this lung ART trial was done. And the thing was that in this lung ART trial also, it was a superiority trial. So it was not a comparative trial. So, and this trial numerically showed better outcome with post-operative RT. But because it was a superiority trial and it has to surpass the superiority hazard ratio boundary also, so which it was not able to do. That was the reason this trial was reported as a negative trial. So see, we have to discuss individual cases with our radiation colleague. So if because most of the times what happens is the patient present to us after a surgeon has done the surgery, and most of the times the mediastinoscopy has not been done for these patients. So we are talking about the ideal scenario in the trial setting where all the patients, they undergo EBUS. Mediastinal pathological staging is done in all of these patients. But what if the surgeon has not done the mediastinal staging and the patient has turned out to be N2 status? So because if your patient pre-operatively was N2, so practically surgery is out of questions. If only if there is a single N2 lymph node which is less than 3 centimeter, then only you can consider the surgery in these patients after some neoadjuvant therapy. So as such, most of our patients, they are not appropriately staged, and I think we have to discuss it in multidisciplinary tumor board. And yes, if this is an ideal scenario where initial mediastinoscopy has been done or EBUS mediastinal staging has been done and it was negative, and later on turned out to be N2, if there is no extracapsular extension, then you can omit post-op RT and you can just save the patient from the toxicity of RT.
So, Dr. Praveen, what I understand that those patients who were not adequately staged, they should undergo radiation after a multidisciplinary discussion, right?
So I think if it is a single station N2, so then we can try to avoid it, because mediastinal radiation also has a lot of adverse event in acute setting also, and they do have late toxicity also. So, but if it is more than one lymph node is there, so probably we should be irradiating these patients. So I think we will move forward. We have already discussed neoadjuvant treatment, and Priyanshu has very well explained this. So now coming to the main point, that post-surgery, the molecular panel report shows EGFR mutation L858R is there. So the burning question is whether you'll go ahead with, because this patient was a node positive patient, whether you'll go ahead with the adjuvant chemotherapy followed by EGFR TKI, or directly EGFR TKI, and which EGFR TKI. So these are few of the questions which always comes in our mind, and we still do not have probably answer, and we will dissect these. So Srijna.
Yes, sir.
So how you are going to approach? P-T2N1 EGFR mutated L858R is present.
I would give adjuvant chemotherapy followed by adjuvant osimertinib.
And what makes you think this?
ये तो stage 2 है and node positive. So in the ADAURA trial, they took patients with and without chemotherapy. We do not know whether the benefit is due to the chemotherapy or with the addition of osimertinib. We do not know the subset. So with the meta-analysis, we have a 5% benefit with the adjuvant chemotherapy. So I would like to give chemotherapy to this patient.
Dr. Priyanshu, your take on this?
Sir, we don't have the OS data of osimertinib yet, but we have the OS data of adjuvant chemotherapy. So I like to use chemotherapy.
So first question is, Priyanshu, first question is, so you are keen in using some EGFR TKI?
Yeah.
Okay. So now, so there are a set of trials which did not proceed with adjuvant chemotherapy. They directly proceeded with EGFR TKI. There is another set of trial where adjuvant chemotherapy was allowed, and after adjuvant chemotherapy, osimertinib or some other TKI was started. So you are taker of which approach? You want to go ahead with adjuvant chemotherapy followed by EGFR TKI, or you directly want to proceed with EGFR TKI?
Sir, one thing is that only TKI, probably first or second generation, would not have advantage, probably because of poor brain penetration, number one. Number two is that my approach would be adjuvant chemotherapy followed by adjuvant TKI, and the preference for TKI would definitely be osimertinib only.
So in ADAURA trial also, so if you take all TKI trials, so what was the chemotherapy rate in RADIANT trial, EVAN trial? So did they do chemotherapy prior to EGFR TKI? So they did not allow this. So they had direct comparison of vinorelbine cisplatin vis-a-vis first generation TKI. So there was a trial, I think this adjuvant CTANG trial, so that allowed. So my point here is we still do not know whether if you are giving EGFR TKI and you are getting benefit of progression-free survival. So that is because of EGFR TKI or that is because of chemotherapy. In fact, if you see ADAURA trial, so 60% of the patient, they received chemotherapy, adjuvant chemotherapy, and 40% of these patients, they did not receive chemotherapy. And this was not because of the stage, because most of the patients, so it was stage 1B, and only minority of the patient, they were less than 4 centimeters. So most of the patient, they were candidate for adjuvant chemotherapy in ADAURA trial. And only 60% of the patient received adjuvant chemotherapy in ADAURA. And there was a recent analysis which was published in 2022, which showed that the benefit of osimertinib was higher in those patients who did not receive adjuvant chemotherapy. However, yes, I definitely agree. So this was not the objective of this trial to discuss whether the adjuvant chemotherapy should be given or not. But this was a analysis which was published in Lancet Oncology, and they showed this, that adjuvant chemotherapy followed by osimertinib was having less benefit as compared to direct osimertinib, and they compared it stage by stage also. So they compared stage 2, stage 3 patient of adjuvant chemotherapy followed by osimertinib vis-a-vis stage 2-3 patient who directly received adjuvant osimertinib. So any take on this, Dr. Manish?
So I think the bottom line is that we don't know exactly what is happening, whether this is because of the PFS advantage which we have at the moment is because of the chemotherapy or osimertinib. So I would say that about 2005 chemotherapy in lung cancer showed a significant survival advantage, and we will
I think, Manish, you have a bad connection. So you have a bad connection. So this was something which I was discussing, that 70% of the patient in ADAURA trial, they were stage 2-3 patient. And in fact, a good amount of patient in stage 1B also. So because they did not categorize less than 4 or more, like stage 1B is more than 3 centimeter. So it also include 3 to 4 centimeter tumor also, and it is also 2 centimeter. So probably a subset of these patients also were candidate for adjuvant chemotherapy. And only 60% of the patient they received adjuvant chemotherapy in osimertinib and 60% in the placebo. And so these were the DFS hazard ratio, which was tremendously improved. The hazard ratio was 0.17. That means 83% risk reduction in terms of progression, disease-free survival, and death. And if we see in the overall population, which also included stage 1B, the hazard ratio was 0.2, and it was statistically significant and meaningful also. So another concern is, so Dr. Srijna, so what do you think? Is it important? So where your disease relapses? So either it is a loco-regional recurrence and or it is a distant metastasis. And what is your what you have seen in your clinical practices that these lung cancer patients most often they have loco-regional recurrences or distant metastasis?
Most of the patients have distant recurrences, sir.
Okay. And what do you think then if the patient is having distant recurrence, so probably then you'll be a taker of osimertinib in all of your patients?
Yes, sir.
Okay. And what about the CNS data? So I would like you to highlight this CNS data of ADAURA trial, and it showed that the initial analysis showed that only 1% of the patient they had CNS recurrence at some time point, and 10% of the patient in the placebo group they had CNS recurrence. And recently the updated result of ADAURA were also presented in ESMO 2022, and they showed that only even after a follow-up of 4 years, so there were only 2% of the patient in osimertinib group who had CNS progression vis-a-vis 13% with the placebo. And what they had noticed was that after giving osimertinib, so they had only 10% of the patient who had distant metastasis, and in fact the loco-regional recurrence also were very, very less. So probably osimertinib had helped in distant metastasis also and the loco-regional recurrence also. And I think this is more to do more than osimertinib. This has more to do with the surgical techniques. So the thing which we were discussing, that there is good amount of improvement in the surgical technique, and a lot of patients now they are undergoing R0 resections, complete resections, probably because of which the loco-regional recurrence were very low in this trial. And in fact, in the placebo group also, the loco-regional recurrence were quite low.
Sir, last 2 minutes to conclude, sir, with your final comments.
Okay. So this is the NCCN guidelines. It suggests that osimertinib should be used in all those patients who are candidate for chemotherapy. So starting from stage 1B to stage 3A, so where surgery has been done and complete resection has been done. And in fact, I would like to highlight one more point. So in ADAURA trial, so they did not allow any neoadjuvant therapy. And in stage 3 patient, when you are directly going ahead with the surgery, that means those patients who receive neoadjuvant followed by surgery vis-a-vis surgery alone. So these patients definitely should be having more micrometastatic deposits, and they should have a poor outcome as compared to those who underwent NACT followed by surgery. So even after that, osimertinib has shown a very good amount of PFS advantage. And the thing, yes, we are waiting for overall survival advantage to be seen with osimertinib. And another point is that in our updated analysis, what was seen was after 3 years of follow-up, so there is definitely a dip in the osimertinib curve, and it is there is waning of effect of osimertinib probably after 3 years. So because 3 years is the time point when osimertinib has been stopped. And I think this is a very, very important question, that in the matured results, when the results mature, so the benefit of PFS, benefit of osimertinib, does it sustain, or it dips down and there is no overall survival advantage in a longer follow-up. So I think this is definitely what we have to see in future results. And till that time, yes, we should always try to give the benefit of osimertinib in all of our patients who are EGFR mutated early stage lung cancer, who has underwent R0 resection, because the hazard ratio of 0.17, 0.2, and even after a follow-up of 4 years, the hazard ratio the hazard ratio is of 0.23. So which is a tremendous improvement in terms of PFS at least. So with this, I would like to end my talk. Thank you all of mine, and for discussing these specific issues on a very good note. Thank you.
Thank you, Dr. Praveen, and that was indeed a very good discussion on early lung cancer, and we all hope that the Tagrisso shows overall survival advantage as well in this setting also, because stage 3 lung cancer patients, they have fewer treatment options. So today we discussed some very important topic on lung cancer updates. And over to you, Mr. Tarun. Thank you so much for attending this event update today. Good night.
Good night.
Yeah, good night, sir.
Good night,
to
sir.
everyone.
Thank you.
Thank you.